Hello, and thank you for viewing our presentation. Today, our team will be presenting on a randomized controlled trial on two prostaglandins, Misoprostol and Dinoprostol, and their efficacy in reducing the time to labor. This is an outline of our presentation. First, we will start off by introducing the concept of cervical ripening and the two prostaglandins. From there, we will move on to the study design, inclusion and exclusion criteria, and then results and discussion. An increasing number of women are undergoing induction to reduce the time to labor. The various methods of induction can be categorized into mechanical and pharmacological. Mechanical methods includes membrane stripping, sweeping, Foley catheter insertion, as well as amniotomy, which is more commonly used in Singapore. Pharmacological methods, on the other hand, uses either prostaglandins or oxytocin. Cervical ripening is the process where the cervix thins, softens, relaxes, and becomes more distensible. This is due to the rearrangement of collagen molecules and the degradation of cross-linking due to proteolytic enzymes, resulting in decreased collagen fiber strength and diminished tensile strength of cervical matrix. The entire process is mediated by PGE2, and this is due to an increase in COX-2, which activates the collagenase and elastase. In this study, the authors aim to compare the efficacy and safety of 200 micrograms of misoprostol versus 10 milligrams of dinoprostone in reducing the time to vaginal delivery. Before we move on to the study design, let us talk about dinoprostone and misoprostol. Dinoprostone is a naturally occurring PGE2, whereas misoprostol is a synthetic PGE1. Both misoprostol and dinoprostone are approved by FDA for cervical ripening. However, misoprostol is contraindicated in women with previous cesarean. This is because collagen softening properties of misoprostol can be absorbed through the cervix and vaginal vault up to the lower transverse scar. This significantly increases the risk of uterine rupture. The key inclusion criteria are as follows: age 18 years old or more, parity 3 or less, singleton pregnancies, 36 weeks or more gestational age, and unfavorable cervix as determined by a Bishop's score of 4 or less, BMI of 50 and below. The key exclusion criteria are uterine or cervical scarring, uterine abnormalities, severe preeclampsia, fetal malpresentation, fetal malformation or compromise, ruptured membranes 48 hours or more before treatment, chorioamnionitis, allergy to prostaglandin, unexplained bleeding after 24 weeks gestational age, or any condition that contraindicates a normal vaginal delivery or requiring urgent delivery. The study design is as follows. This is a double-blinded randomized controlled trial involving 1,358 subjects across 35 centers in the United States. There are two arms in this trial. One arm is given 200 micrograms of misoprostol, whereas the other arm is given 10 milligrams of dinoprostone. The primary endpoint of this trial is the time from study drug administration to vaginal delivery. But the authors also measured secondary endpoints such as the time to onset of active labor, time to any delivery, and the proportion requiring oxytocin. The measure of safety is the rate of cesarean delivery. Once enrolled into the study drug is inserted into the posterior fornix of the subjects. This is followed by a 6-hourly vaginal examination. Removal of the study drug is indicated at the onset of active labor, which is defined as 3 or more contractions in 10 minutes, lasting 45 seconds or more, and also 4 cm dilation. Removal of drug is also indicated after completion of 24 hours. Oxytocin was permitted 30 minutes after removal of insert if patient was not in active labor. This slide shows an overview of the results for this study. The percentage of vaginal delivery for Misoprostol and Dinoprostone vaginal insert was 73.3% and 71.6% respectively. Percentage of cesarean delivery for Misoprostol and Dinoprostone vaginal insert were 26% and 27.1% respectively. As you can see, there is just marginal differences between Misoprostol and Dinoprostone vaginal insert for both types of delivery methods. This slide shows the time to vaginal delivery in hours. The primary endpoint for this trial is the median time to vaginal delivery. Comparing between Misoprostol and Dinoprostone, the time taken are 21.5 hours and 32.8 hours respectively, and the difference has been found to be statistically significant. For nulliparous subjects, time taken are 29.2 hours and 43.1 hours respectively, and this is statistically significant. For parous subjects, time taken are 13.4 hours and 20.1 hours respectively. The secondary endpoint, as Watt pointed out in the earlier slides, are the median time to any delivery in hours, median time to active labor in hours, and the proportion of women requiring pre-delivery oxytocin. From the results presented in the table, we can see that there are significant differences in each of the measuring bar, and they have been found to be statistically significant. Overall, Misoprostol requires a shorter median time to any form of deliveries as well as time to active labor. It has also been found that most common reasons for cesarean delivery for both types of inserts were adverse events, elective cesarean, and the lack of efficacy. However, among the adverse events leading up to cesarean delivery, it was found that there were some differences. For Misoprostol vaginal insert, it is usually due to category 2 fetal heart rate pattern and uterine tachysystole with late decelerations, bradycardia, or prolonged decelerations, as shown in the highlighted boxes. For Dinoprostone, it is due to arrest of dilatation and the arrest of descent. In summary of the results, there were no significant differences between the two treatment groups who experienced adverse events in intrapartum, postpartum, and neonatal period. There is also no significant difference in fetal heart rate, category 2 and 3. However, one significant difference was that adverse event tachysystole requiring intervention occurred in more women receiving misoprostol than dinoprostone. This percentage difference was 13.3% and 4% respectively, and this difference has been found to be statistically significant.
This brings us to the discussion of our paper. It is important to know what studies have been done with regards to the use of misoprostol and dinoprostone in terms of cervical ripening. This is a list of some of the trials that have been done in the past, which compare both dinoprostone and misoprostol. In particular to note is Professor T.C. Tan's randomized control trial, which was done here in Singapore, which did find that 50 micrograms of misoprostol has similar efficacy to dinoprostone. Do keep in mind that the trial we are presenting today uses 200 micrograms of misoprostol rather than the 50 micrograms that were used in Professor T.C. Tan's trial. This slide summarizes the results from the trials that were listed on the previous slide. What the literature says is that most studies showed efficacy of misoprostol in both nulliparous and multiparous women, as well as both oral and vaginal inserts of misoprostol can achieve similar or even higher efficacy to dinoprostol. Efficacy of misoprostol is dose dependent, which again brings us back to our point about the use of 200 micrograms of misoprostol in this trial, as well as the fact that increasing risk of tachysystole was found with increasing dose of misoprostol, which again was something that was found in our trial. Vigorous titrating of misoprostol dosing enhances safety. Low-dose regimen of misoprostol showed to be as efficacious as dinoprostone, and this talks about Professor T.C. Tan's study on misoprostol vaginal insert, which showed similar efficacy to dinoprostone. What the guidelines tell us so far. The 2011 WHO recommendations for induction of labor recommend oral misoprostol 25 micrograms 2 hourly or a vaginal misoprostol low dose 25 micrograms 6 hourly. 2008 NICE guidelines, which were reviewed in 2011 for induction of labor, recommend dinoprostone gel or tablets 6 hourly, maximum 2 doses, or vaginal prostaglandin E2, which is dinoprostone controlled release pessary, 1 dose over 24 hours. And the NICE guidelines specifically do state that misoprostol should not be used. While the 2007 ACOG guidelines suggest the use of vaginal misoprostol 25 micrograms as initial dose 3 to 6 hourly, or vaginal dinoprostone 10 milligrams 6 to 12 hourly. One of the contraindications is if there is a high risk of uterine rupture. So what is done well about this trial? This is a large-scale phase 3 double-blind multi-center randomized control trial with stringent inclusion and exclusion criteria which minimizes confounding variables. It compared both nulli and multiparous deliveries as well as compared multiple parameters including primary and secondary endpoints, as well as the fact that adverse fetal effects were studied in view of the expected higher rate of tachysystole induced by misoprostol. However, does this trial justify clinical use of the insert? It is important to keep in mind why we would have this difference in timing with dinoprostone and misoprostol. So there are some contributing factors. One of the contributing factors may be the investigator's decision to keep the dinoprostone insert in place for up to 24 hours, rather than the manufacturer recommended 12 hours. This, of course, could lead to a potential delay in oxytocin initiation and therefore delivery. However, it is likely that most of the difference comes from the fact that we are using 200 micrograms of misoprostol in this trial, which is significantly higher than the dosages used in the past. And I would strongly recommend browsing through Rouse's review, the reference of which is given at the end of these slides, on this trial, which stated very eloquently that misoprostol insert led to more uterine contractions, which is not necessarily a good thing. Just as driving 100 miles per hour may get you home from work a bit earlier, but is usually not a good idea. In addition, the results of these trials are not surprising. They are consistent with the 2010 Cochrane Systemic Review, Vaginal Misoprostol for Cervical Ripening and Induction of Labor, which did find similar results, which was that misoprostol led to a shorter time to delivery, but with the cost of tachysystole. So the significant differences which we would like to point out that may not warrant the use of this insert clinically is that the fact that tachysystole was found in 13.3% of the misoprostol arm versus 4.0% in the dinoprostone arm, as well as 4 times the proportion in the dinoprostone group experienced tachysystole in association with late fetal heart rate decelerations, prolonged decelerations, or fetal bradycardia. And tocolysis use was 12.2% in the misoprostol arm versus 4.1% in the dinoprostone arm. And even though it is important to note that even though no difference occurred in fetal adverse events, 5-minute APGAR scores below 7 occurred twice as often in the misoprostol group. This trial also brings out the point about the role of Foley catheter in light of tachysystole as a common effect of prostaglandin use. So a 2011 meta-analysis of 9 studies, which studied 1,603 patients, compared intravaginal misoprostol and a Foley catheter for induction of labor. And the results were that the time of delivery, the risk of chorioamnionitis, and the risk of cesarean delivery were not significantly different between the two methods of induction of labor. However, the rate of tachysystole was significantly higher with misoprostol, with a relative risk of 2.844. As the ultimate goal of cervical ripening is to reduce the rate of cesarean delivery, and the fact that there is no significant difference in this trial in the misoprostol arm and the dinoprostone arm in terms of the rate of cesarean delivery, whether it is justified to have this increase in cost with the use of misoprostol, especially in light of the increased rate of tachysystole requiring intervention. So this misoprostol insert has been trademarked as Misodel by Ferring Pharmaceuticals, and it is a single application removable controlled release vaginal delivery system containing 200 micrograms of misoprostol released at 7 micrograms per hour over 24 hours. And since the major factor here is the decreased time to delivery, whether this cost is justified. And to give you an example of what can happen with unjustified increase in healthcare costs, I will point to Makena, which is 17-alpha hydroxyprogesterone caproate, which was trademarked as an orphan drug in the United States, increasing the cost from around $300 per pregnancy to about $30,000 per pregnancy, which is a significant increase in cost. And this formulation was not different from the compounded formulations which were sold by pharmaceutical companies prior to this. So this is an example of unjustified increase in healthcare costs. Obviously, with Misodel, we do not expect such drastic results, but it is interesting to know, to keep in mind always the cost of introducing a new drug and whether these costs are justified. That is all for our presentation. The following are the references we used, and if you are more interested in reading about these, please have a look at these ones.